Hello there, this is Dr. Mintz. This is a CT of the abdomen and pelvis in a woman who has just had a cesarean section a few days earlier, came back with severe abdominal pain and nausea. I'll scroll through these images and allow you to kind of gather a general impression as to what's happening here. Okay, let's first look at some of the structures that we know for sure. And good old liver is usually quite readily identifiable. The left lobe of the liver and right lobe are divided at about this area here. And so this is lateral segment and medial segment of the left lobe. And here's right lobe of the liver. You see pancreas here. That's pancreas. The common bile duct comes from the liver down through the head of the pancreas, and that's that little tiny dot right there. Common bile duct, and empties into the duodenum. You see both kidneys here. Here's the abdominal aorta and IVC, which you can follow along their respective courses. The IVC, interestingly, dives into the substance of the liver and then courses superiorly to join the right atrium. So, how about the bowel? Well, the bowel looks abnormal, and we don't see very much in the way of normal appearing bowel loops, but we do have oral contrast filling some loops, and here you can see what looks like small bowel. You see the closely spaced folds in the small bowel of jejunum. Ileum has less of those. This looks like colon with some stool. Colon with stool. And this looks like cecum. And here we have a little anatomic structure, a narrow tubular structure that is continuous with the small bowel opacification here. So this is terminal ileum. So here you can see there are small bowel loops with oral contrast, and here you see a segment of distal ileum, and if you follow it, even though it's subtle, you see that little bit of contrast there. You see a little wisp of a line here. It's usually more obvious than that. You see this, and it's coming in right here to a segment, an anatomic structure that is between the cecum, and the cecum is in this case kind of directed anteriorly, and the right colon. And the right colon we can follow up superiorly in this manner, and then it becomes the transverse colon, and it becomes then the descending colon in here, and it's hard to follow after that point. But certainly down here in the lower pelvis we can say that I identify the rectum, and ventral to the rectum is a fluid collection that does not appear to be intraluminal. Here's the uterus, so the retrovesical, retrouterine pouch is clearly filled with a large amount of fluid and some air, and it appears that that's extraluminal. So part of the puzzle here is to try to figure out how much of what we're seeing as fluid-filled structures is actually bowel and how much is extraluminal collections of fluid and, 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 which would basically mean abscesses. Well, as we said, we have some oral contrast in the small bowel, and you can see it here in the stomach as well. So it's in the stomach and small bowel. It's evident in the duodenum. So we follow the stomach over here in about this area, right next to the gallbladder. There's the gallbladder. You're seeing the first portion of the duodenum, and then as you course inferiorly, you're seeing the second portion of the duodenum, and then as it crosses the midline across like this, it's the third portion of the duodenum, and then superior to that, just a very short segment, is the fourth portion of the duodenum, and from there it empties into the jejunum. And here we see jejunum. We see small bowel loops with the typical jejunal folds, and it's hard to follow because I believe the jejunal loops and some of the ileum are effaced by these processes that are occurring, but it is possible that, though, to get some idea of where the bowel is and to follow it. And as I mentioned before, we can follow it into here, into the terminal ileum, where it empties into the right colon, immediately distal to the cecum. So here's cecum, here's the terminal ileum coming in, here's right colon. And remember, it may not look like the orientation you would ordinarily expect for cecum and right colon and terminal ileum, but it's anatomic relationships, not the way that it looks, that's going to determine what you are looking at. So we have identified quite a bit of bowel here. So then that leaves us with structures like this. Here's a large structure with air fluid level. Here's something that is apparently apart from any of the identifiable bowel loops that we have seen, also containing fluid and air, and it's abutting the liver. Here's a structure abutting the medial aspect of the right lobe of the liver, also containing fluid and air. Here's some air that is in between some loops of bowel, small bowel above and, or I should say, anterior and posterior to this. That air and fluid is also very likely to represent abscess. So all of these places that we're seeing air and fluid are abscesses. Here's a big loculated collection of fluid and air. Most of these are between loops of bowel or between the inner lining of the abdominal cavity and bowel. So this is numerous abscesses in a patient who had a cesarean section, and this has happened presumably because bowel was inadvertently harmed, cut, or nicked, and there was leakage of bowel content into the peritoneal cavity. And I guess that's probably one of the most important aspects of this case, is to illustrate the variety of spaces within the peritoneal space that can be filled with fluid. In other words, when you're looking here, this big collection here, and this big collection here, and this big collection here and here. These are all in the peritoneal space, which is normally only a virtual space. It's a space that is lined by peritoneum, that is wet, and therefore allows the bowel to slither and slide around without any significant frictional forces. But that potential space can be expanded into a real space. So if there's an infection, and multiple abscesses will certainly satisfy that requirement, then these multiple abscesses distend and fill up various portions of this peritoneal cavity. So what you're seeing then is the virtual spaces of the peritoneum or of the peritoneal cavity being distended and filled with infectious processes, multiple abscesses containing various amounts of fluid with pus and air. So this gives you a perspective on the peritoneal cavity that is interesting, I hope, and it also is a little different than what you see when you just have free fluid in the abdomen. And ascites is an example of free fluid in the abdomen where you will see loops of bowel with fluid in between them, but not in this kind of pattern with geographically defined areas of fluid in some areas and none in other areas. So this is a very dramatic case then of a patient with multiple peritoneal abscesses occupying spaces between loops of bowel and adjacent to loops of bowel in the abdomen and pelvis.